Chris, do you want to introduce John?
Yeah, absolutely. John Sisti is a fellow in Neuroendovascular. He's been with us for about a year. And like other great fellows who have come through this program, he came to us from Columbia. Just kidding. He was at Columbia Neurosurgery resident, graduated a year ago. He's going on to a endoscopic fellowship at USC, and he'll be looking for neuroendovascular endoscopic positions afterwards. He's been excellent to work with in the angio suite, excellent communicator, and very innovative in some of the ideas. It's always fun to do cases with him and talk about what's possible. So I'm really looking forward to this talk.
Thank you, Dr. Kellner. And thank you, Mir, for your talk as well. It's been a pleasure working with you throughout this year, and congratulations on your match, and congratulations to everyone, all the incoming interns who are coming in as well. It's an amazing field, and I hope I can speak a little bit to that today. Again, my name is Jonathan Sisti. I'm the current endovascular fellow here, for those of you who haven't met me yet. And today I'm going to talk to you about several projects I've worked in the past that are in the general realm of technology. Again, I think Mount Sinai has a really good reputation, a lot from the biodesign lab, of being at the bleeding edge of surgical innovation. And I think it's really incredible what you guys have built here. So I hope you enjoy my talk and hearing about some projects that I've worked on. So right now we live not in the world of Google anymore. Now we live in the world of ChatGPT. So if we're going to ask ourselves, what is disruptive tech? Again, this isn't something we would Google. This is something we would just go straight to the source. For those of you who haven't used ChatGPT, it's free, and you literally just ask it a question, and its responses are generally pretty good. So if we ask it, what is disruptive tech and how might it change the future of neurosurgery? Gives us a really good definition. It says it refers to innovation or technology that significantly alters an existing industry or creates a new one by introducing a novel approach, often resulting in the displacement of established players or traditional methods. And then as it goes for neurosurgery, it gives us a really good list. It says, robotics and AI, virtual reality and augmented reality, BCI, nanotechnology, and telemedicine and remote monitoring. So pretty good list. Disruptive technology, these are just some examples in other industries, but I think we as neurosurgeons are no strangers to disruptive tech, through our history from the advent of the CAT scanner, MRI imaging, the Malus bipolar, deep brain stimulation, coil embolization, flow diverters. There have been a lot of technologies that have been paradigm shifters in how we practice medicine. And I think we as neurosurgeons generally are good early adopters of these technologies because of out of necessity, because of the complexity of the problems that we're faced with on a day-to-day. So disruptive tech per ChatGPT, as it pertains to neurosurgery, it gave us a list of 6 things. I have personal experience in 5 of these. So that's just briefly what I'm going to speak to you guys about today. My journey in technology kind of started in undergrad. I was working in a civil engineering lab, the Project Network Dynamics lab. And what we were tasked with was to create a virtual world where we could study how civil engineering students worked and collaborated real time in a virtual environment. So we use this game engine that's typically used to make video games called Unity to build this world we called CyberGrid. And you can see here we would have, civil engineers would build different projects, and we would record their interactions and study those interactions. And so this is where I got a lot of my technical skills from. I was fortunate enough to be able to volunteer building software for the motor performance lab for these 3 neurologists, Pietro Mazzoni, John Krakauer, and Seth Pullman. And I saw how they were using video games to quantify motor performance diseases and study them further. And this really captivated my imagination, and I kind of fell in love with it. I loved working with them, and it was a big inspiration for me to apply my technical skills in a more clinical context. Around the same time, the iPad came out, and this was just the coolest thing. Immediately I saw its potential as a clinical tool to get data that previously just was not available to us. And so I worked very closely with Dr. Pullman to create what I called NeuroSpiral. And this was my first iPad application that I created. That was the first iPad app really in the world to collect and analyze kinematic patient data. And we did a study where we validated this. You would have a patient with Parkinson's disease, for example, draw an Archimedean spiral, and they would automatically generate a score from 1 to 4 on degree of severity. I released the app through Columbia Technology Ventures, not necessarily something I recommend doing if you can avoid it. But it was the second app they ever released. And at the time, it was ranked as the top medical app in the world. It was downloaded several thousand times over in many, many different countries. I wrote this in the programming language Swift, which has since been deprecated. And because residency was kind of busy, I wasn't able to update it, but I still to this day get emails about people who are using this in their clinic all over the world. So that was a really cool project. Ever since then, we now live in the world of the tablet. A house in the United States household is more likely to have an iPad than not. And I worked making various different apps that would automatically collect and analyze patient data. But Apple really has kind of taken this to a whole other level. Now, everyone carries around an iPhone or a smartphone or an Apple Watch, and we as clinicians have free access to all this data, which is now Apple has taken upon themselves to validate. And it gets quite sophisticated, from step count, step length. They have walking speed, double support time, and walking asymmetry. And this is something that Dr. Connolly was really interested back in the day in quantifying using a Fitbit, but now you really don't need any of that. All the kinematic data that the iPhone and Apple Watch collect is very high quality and, again, available to us. And then an interesting future direction that not a lot of people think about is the way in which our iPhones actually track each watt of power. And this, I think, could be a potential interesting biomarker for cognitive functioning, and something that I'd be interested in looking at in the future. But every watt that you use on your phone is actually tracked. Are you playing games? Are you communicating? Are you using the internet? How are you using the internet? And this could be a possible interesting future direction. So now we have all this data, but how do we really drink from the fire hose, so to speak? And that's where machine learning comes into play. For those of you who don't know what machine learning is, it's a subfield of artificial intelligence that focuses on the development of algorithms and models that enable computer systems to learn and improve from data without being explicitly programmed. It involves the construction of mathematical models and algorithms that analyze and interpret data, identify patterns, and make predictions or decisions based on data. And you can see, if you do a PubMed query, there's been a recent explosion in the neurosurgical literature that uses machine learning in one way or another. There's two typical ways that you train a model. One is supervised and the other is unsupervised. Supervised is where you feed a model classified data, you label it for it. And then when you give it a new novel piece of data, it will use the training data you provided it to classify the novel data. And then another one is unsupervised, where in a kind of higher dimensional sense, it will cluster similar objects together. And this will unveil patterns that you maybe didn't know were there. An example of an algorithm that does this would be like k-means clustering. So we were early adopters of this. I used a random forest machine learning model to prognosticate functional outcome and intracerebral hemorrhage. This was using our iChop database, and basically it would tell you the chance of a good or bad outcome. It was a dichotomized MRS, 1 or 2 being good, above that being bad, at 3 and 12 months. But we're seeing now how AI is really here to stay. Again, we use it in our almost every day now. Viz AI is a great example of just the power of AI and computer vision and its automated analysis of CAT scans and identification of LVOs, aneurysms. And I think that this is just going to make our job easier. Again, we can see how powerful these tools really can be. This is a Dolly-generated painting. I used the prompt "confused neurosurgeon fighting a computer" impressionistic style, and I swear this could be one of my old attendings. If I lost you at machine learning and you don't take anything else away from this talk, just take away this. Again, we have all these data sets. I mean, maybe you have data pertaining to microelectrode recordings or stroke outcomes data. It could literally be anything. And you're interested in applying a machine learning model to that, but maybe you don't have a technical background. So what do? Again, we don't live in the world of Google anymore. Now we live in the world of ChatGPT. So if you literally just ask ChatGPT, here I have a prompt, I want to make a machine learning model to prognosticate outcome in patients who present to the hospital with stroke. I have a large data set where each column represents a patient, and the rows contain information from their medical charts that include demographic information, vitals, labs, et cetera, et cetera. It will give you literally a recipe of exactly what I did many years ago. But I had to actually do research, talk to people, and figure this out. And we'll give you a step-by-step process of exactly what you need to do to apply your machine learning, apply a machine learning algorithm to your data. And then if you have any specific questions, it will address those questions in a more nuanced way. And it even gives you the Python code to use a Scikit, which is a very well-known kind of open source machine learning library that's, again, free to use. And you can just copy and paste this, and it will take you through how to do machine learning for your data set. And you can do this today, and there's no reason you really shouldn't. So technology is really making these tools available to the layman or us, and it's quite powerful and, again, easy to use. You can just have a conversation with ChatGPT and again, get a very powerful machine learning algorithm to classify or analyze your data. 3D printing is another really cool one. I think it's completely changed the game of cranioplasty, obviously. In training, they now have these beautiful models. This is an ACDF model. And now they have all kinds of sophisticated ways of doing composite printing. It's integral for some surgeons in surgical planning. If you ever find yourself at the Allen Pavilion in Dr. Lanke's office, his wall is literally filled with these 3D printed spines, and he'll 3D print the spine of a complicated case a week or so before, and you'll see him just carrying around the thing, pondering it, looking at it, and that's important in his overall surgical process. The future is really cool. There's this thing, generative design AI, where in a pseudo-stochastic way, computers are now able to create 10, 20, 100 million iterations of a component, test it, and then in an evolutionary sense, take parts of it that are good and then improve upon it. And you get these really cool, organic, crazy designs. This, I think, is a motorcycle component that is lighter, stronger, more efficient than anything a human being could create. So I'd be interested to see how this will be applied in neurosurgery. And of course, bioprinting and printing surgical tools. These are aneurysm clips that you can print. Of course, you wouldn't actually use them, but it's pretty easy to do. We did publish on this in 2017, but since then, the technology has completely changed, and it's changing on a month-to-month basis, really. 3D printing, again, is very easy to do. This is an aneurysm. I used to print aneurysms for patients. They loved it. It takes a couple minutes. It's really not that complicated. And again, if you have any questions, you can always ask ChatGPT, or you can just print a Coliseum if you're bored, because why not? BCI, so some of this stuff might look familiar. This really, I think, is the pinnacle of technological innovation in neurosurgery. This stuff is like magic. We're making blind people see, paralyzed people walk. The sky is the limit with this stuff, and it's super cool to see and be part of neurosurgery. I feel like we're at this very interesting point in time where this stuff is really exploding, and I think it's only going to get better and better. At Columbia, I was fortunate enough to work in a collaboration with the Shepherd Lab. This was, the device is here on the right. It was a wireless vagal nerve stimulator that I would endovascularly deploy in a rabbit model. I do a femoral artery and vein cut down and then get arterial and venous access. This is a custom chip made in TSMC that they would mount on this flexible custom copolymer, which would then be rolled up and placed in a delivery catheter. It's my job to get the catheter up there into the neck, deploy the device, and then using ultrasound, focused ultrasound, it would resonate a piezoelectric crystal, which would generate a charge, and then that charge would then emit an electromagnetic field from these electrodes, which would change the heart rate of the rabbit. And this venous catheter would be like a small antenna, so we could see the power output of the device. And this was a really cool project to work on. We're right now working on submitting this to Nature BME. Resistance is futile. The last couple things I wanted to talk to you all about is augmented reality and virtual reality. I'm really a big believer. I think it's been definitively shown that augmented reality improves operative efficiency. I'm a big believer of this for sure. I did study a little bit the effects of post-traumatic stress disorder and realized that, there's, I think, a big unmet or undiscussed source of morbidity and mortality in a lot of ICU patients and neurosurgical patients in general, that I was interested in addressing using virtual reality exposure therapy. This was really pioneered by DARPA. They and people who came back from Vietnam who had really complex PTSD, they found that by habituating them to certain stimuli that cause them to have symptoms, they were able to really help Vietnam veterans. And so now in the world of now we live in a world of virtual reality. You're able to, if you have agoraphobia, you can simulate being in a crowd, or if you have a fear of heights, you can, again, in a graded, safe environment, start exposing yourself to that stimulus. Unfortunately, I didn't get a lab year. I was planning on working on this, but COVID hit. As everyone here is, I'm sure, is well aware, New York was hit pretty hard. And if you, in peak COVID, if you were admitted to NYP in October, the chance of you dying was over 50%. And early on, it was pretty dark. We didn't really know how to help these people. I felt pretty helpless, but eventually we did get better. And it was an interesting kind of melting pot type of situation where I was working with a lot of people I otherwise wouldn't, which included a lot of psychiatrists. And I thought to myself, and I was talking to my colleagues about how, we were worried that there would be this second epidemic, the second wave of post-traumatic stress, where people who, survived COVID would be traumatized by their experiences. So I worked with them to create a virtual reality exposure therapy to address post-intensive care syndrome, which is defined as a new or worsening impairment in physical, cognitive, or psychiatric health that results from critical illness and persists following discharge from intensive care. And this was a really cool project. It was interesting to see when I reintroduced people to their ICU room, as well as sounds. They had heard the sounds in their dreams, and they were like, "Oh my God, that's what that is." And this was a really cool project to work on. How we did it is I applied for some grant money. I got funding. I bought this 360 camera, which I dangled from one of our ICU beds. And then we would have various scenarios that we would also play out. This, again, would be like a gradual exposure. There I am, our ICU. And what I learned really are these core tenets of exposure therapy: repetition and habituation, control and agency, gradual progression, immersion and accuracy, and accessibility. There's a lot of really good VR devices that have a wide range of price, from Google Cardboard to more recently Apple Vision Pro, which would be awesome to have one day, but is way too expensive. And in terms of the way in which people consume the content is also important, because you want it to be accessible. And YouTube 360 is actually phenomenal. This is an example of a video, like a 360 video that takes you through what you do if your car is submerged in water. It's scalable, accessible, cost-effective, has robust quantitative analytics, interactive, and multi-platform. And this is what we actually used for our study. So I saw a natural way of moving this kind of what I had learned to neurosurgery. And so this is, again, an ongoing study that's happening right now at Columbia, where we are introducing exposure therapy for conscious sedation in neurosurgery. And you can see here, this is a typical awake craniotomy setup. And this is the COO camera with a stereoscopic microphone kind of in the same position that the patient is in. And this is, again, what you would see from the patient's perspective. You can do this in 2 dimensions or 3 dimensions. And the idea is to pre-expose people before their surgery by having them consume this content in the comfort of their home. So again, we are doing this for, actually how I started it was in the angiogram suite, because most of our diagnostic angiograms are under conscious sedation. So we would have people practice don't breathe, move, speak, or swallow, that kind of stuff at home. And then they would be able to either wear a VR headset or just watch it on their iPhone, a video of the actual angiogram suite with similar sounds. And we move around the C-arms and simulate a procedure before their actual procedure, so that they can practice at home things that we're going to ask them. So predicted outcomes: improve patient satisfaction, decrease anesthetic complications, lower intraoperative anesthetic requirement, decrease incidence of hypoventilation, delirium, hemodynamic variability, better duration and proportion of desired RAS, unanticipated transitions from conscious sedation to general sedation, better surgical outcomes possibly, faster, longer, and improved intraoperative mapping and possibly extent of resection for awake craniotomy, picture quality in digital subtraction angiography, and quality of neuropsychologic testing during DBS, and possibly decreased length of stay, morbidity, and mortality. You really can, again, the sky's the limit. You can take this as far as you want. You could gamify it to, encourage people to participate. I had this idea of doing complete demystification, is what I called it, from registration to parking lot, where you would show a person exactly the path they're going to take from registration to the pre-op area to the operating room, and then you would show them their ICU bed and the floor. So that their entire hospital stay would not be any, there would be no question about it. They would know exactly what they're going to experience. And the general idea is to broaden the safety, indication, and utilization of conscious sedation within neurosurgery through patient education in a manner that is safe, scalable, cost-effective, and accessible. So there's one more thing that I briefly wanted to speak with you all about. And that is David Zweibel. So, David was my good friend. He was my brother-in-law, for lack of a better word. Audrey's kind of adopted brother. And he passed away a year ago, Memorial Day 2023, from GBM. And I learned a lot about glioblastoma, more than I really ever wanted to, and more than I hope anyone ever has to, and through his journey. And one thing that really, I think, stuck with me was just the true invasive nature of this disease. Yes, it goes beyond the margin, but GBM spreads far beyond that. It affects family, friends, communities in ways that I didn't really appreciate before David got sick. And the thought of someone having to go through this experience alone, I mean, David had me, he had my family, Audrey and her family, to help, navigate the complicated medical system. But the thought of someone having to go through this alone really kind of bothered me. And I thought, what can we do to address this? And what I think I love about technology is, it's cold and seemingly indifferent to human suffering, but it does seem to foster the best thing we have in our fight against terminal illness, which is each other. It has this ability, when implemented in the right way, to really bring people together. And one interesting way recently that's come out is the metaverse of doing this. Again, the metaverse, I think, is kind of in its infancy, but it is kind of exciting to see where this technology will go. And, I built, in David's honor, the first of its kind virtual neurologic institute in Meta Horizon Worlds. And you can see this is the building here. The idea was to have a virtual kind of group support group where people could meet up in the metaverse. So welcome to the Virtual Neurologic Institute. Our goal is to use the metaverse as a way for patients and their families and friends to meet with one another from across the globe in a safe, anonymous, and comfortable environment. We want people who or have been affected by a large variety of neurologic disorders to share their stories, experience, and insights with one another. We hope to harness the power of the metaverse and use it as a force of healing. So again, this is just an example of the way we can use technology, and a way I think we should use technology to really bring people together to kind of fight these diseases. So in conclusion, we now have the ability to expand the paradigm of compassionate care through the lens of technology to foster real human connection and lessen the suffering of patients and their families. The future is now. The pace of technological advancement is increasing at an increasing rate. We have an obligation to understand these technologies and participate in their clinical application, since we will always have the best interest of the patient in mind. And it's an incredibly exciting time and has never been more promising to be in the field of neurosurgery. So thank you all for listening to me, and thank you to everyone for just an amazing year. I really could not be more grateful. I've learned so much, and it really has been fantastic. So thank you all.
Thanks a lot, John, for a really cool update. I didn't know that was possible with ChatGPT even now. So it's really, really interesting. I remember when you did that spiral back in residency. I was actually in Sanders' lab at the time, and we started using it with some patients. So it was very cool.
Yeah, I actually made a neuropsychologic battery that had Trails AB Ray Complex figure for you guys, I remember. And then I think some lawyer sent me an email saying basically all that stuff was copyrighted, and they forced me to take the app down. But I think that, again, if the possibilities are limitless, with using the iPad as this kind of tool to get this data that previously just wasn't accessible to us.
Great talk, John. I was looking at the prompts available to you when you showed the Chat GPT. The one that stood out to me was plan a relaxing day.
Exactly.
Particularly after this talk.
Yeah, thank you.
Strong work, really, really strong work. It shows that you're excited about what you're doing and passionate, allowing you to really harness your skill towards this. It's wonderful.
Thank you.
All right, thank you, everyone. So for the next part, we're going to have everyone except for clinical faculty log off for a professionalism working group discussion. Chris, I'll look at the participant list as people log off and make sure everyone gets off before we start.
It's like we got everybody there.
Almost.
Yeah, let me know when the list is ready.